Welcome to Module 6, Resource and Capacity Building for Local Health Departments. In this module, we'll explore how to maximize your existing capacity, develop your workforce, and build infrastructure that supports strong CHA-CHIP implementation, especially in resource-constrained environments. We know that most local health departments are balancing limited budgets, small teams, and growing responsibilities. This module offers realistic, adaptable strategies to help you stretch what you have, share across agencies, and seek sustainable funding, all while investing in the skills that make your CHA-CHIP process resilient. So let's get started. Doing more with less has become a reality for many local health departments, but that doesn't mean you can't lead a strong CHA-CHIP process. Maximizing impact starts with a mindset shift. Focus on what you have and how it can be leveraged creatively. That might include tapping into your existing staff's hidden skills, like maybe some like graphic design, some like facilitation, maybe some are better at grant writing. Look into free tools like Google Forms. Canva has a free version. A lot of different software out there to organize CHA tasks. And repurpose your slides, templates, and content from previous assessments. And you also might consider looking at what kind of partnerships are available with students, interns, or volunteers from local universities. The most effective CHA-CHIP teams aren't necessarily the largest, they're the most resourceful. This module will share examples of how Nebraska health departments are doing that. So during our CHA-CHIP training needs assessment, local health departments across Nebraska shared several consistent challenges. Staffing capacity was a really big one. Departments often have one person juggling data, facilitation, planning. And there's funding gaps and grant dependency. And the CHA-CHIP work is often underfunded or pieced together from multiple sources. And there's time constraints in aligning timelines. So planning cycles collide with outbreaks, inspections, grant deadlines, different interests, like one hospital needs it done in November, the other one needs it done by December, and October. And so there's not a lot of consistency sometimes in like timelines at the hospitals as well. And then that can lead to duplication across your local and regional partners. So a hospital might do a needs assessment of their own if you don't have that relationship established and that interdependency in place. Then there's also documentation and evaluation challenges, teams struggling to track engagement or implementation once the chip is launched. And these aren't just isolated problems, they're systemic. That's why we framed this module around 3 pillars: stretching what you have, sharing across agencies, and seeking sustainable funding. And one thing I haven't mentioned yet also is about burnout and turnover. Sometimes if we stretch ourselves too thin, creates burnout, which can lead to turnover, which is why it's so important to share across agencies and seek more sustainable funding. So the first strategy is to stretch your existing resources. So this can mean bringing in students or interns to support data entry, survey collection, or meeting facilitation. Using free or low-cost templates to reduce staff time spent building materials from scratch. Encouraging internal cross-training. So if your data analyst can also facilitate a partner meeting, you gain flexibility without having to hire new staff or contract out for that. And use simple planning tools like maybe Trello or just Excel spreadsheets to manage workflows. Even small efficiencies can all add up as long as you're keeping track of your system. The goal is not to overwork your team, but to distribute tasks strategically and empower your staff to contribute across the process. The second strategy is to share across agencies, especially for data collection, analysis, or reporting. In Nebraska, several regions have begun collaborating on shared CHA-CHIP efforts. For example, some districts combine staff to lead regional surveys. Others pool funding to hire a shared data analyst. A few have developed joint dashboards or CHIP templates. This kind of inter-health department collaboration doesn't just save money, it builds consistency across jurisdictions and increases access to expertise that may not be available in-house. You don't have to do everything alone. Shared services can make things that are very difficult in isolation much more manageable. There's a lot of examples of shared services out there if you look at statewide and nationally as well. So strong CHOT processes depend on skilled staff, but many health departments don't have full-time positions dedicated to community health planning. So workforce development becomes essential. Here are a few practices to consider. Focus on core competencies. These include data analysis, facilitation, equity-centered engagement, and strategic planning. Not everyone needs to be an expert in all areas, but every team should have access to these skills. Create internal cross-training opportunities. If your epidemiologist understands community engagement and your planner knows basic Excel functions, your team becomes more nimble and resilient. Build communities of practice. NACHO offers an accreditation community of practice, and Nebraska has several informal groups where peer learning happens. Leverage partner-delivered training. Universities and nonprofit partners often offer free or low-cost training, such as QI workshops or facilitation training. When you invest in your people, you strengthen your system. So now let's talk about funding and securing funding, which is a very challenging thing in today's climate. CHOT efforts often fall between budget lines, but you can position them as essential infrastructure and try to fund them accordingly with that justification. So these are just ideas. You might consider starting by aligning your CHA with hospital CHNA timelines. So this opens the door to shared funding and co-branding community engagement efforts. Using your CHA data to justify CHIP mini grants, especially around behavioral health, social determinants, or equity goals. So some communities might have access to funding resources in their community. There might be more regional ones, but there's a lot of them out there. So it's about finding them and maximizing your access and relationship with them. Creating a grant boilerplate, a document that includes your health department's mission, recent CHA findings, and your top CHIP priorities. This saves time when writing proposals and keeps your messaging consistent. And remember, there are funding sources that welcome CHA-aligned work, including NACHO model practices, HRSA community-based funding, local foundations or donor-advised funds, even regional health systems interested in population health metrics. Your CHIP work isn't just important, it can be fundable if framed the right way. In Nebraska, we've seen creative examples of health departments stretching, sharing, and seeking successfully. There's been epidemiology capacity distributed across. One health department had AmeriCorps working with them. Another community had a regional CHA with one contracted person supporting the entire region. Another health department had access to a funder and did CHIP mini grants supporting outreach materials and youth-led health boards. And nationwide, there are hundreds of examples of stuff like this. So the internet's a wonderful place. I'd advise you dive in and just kind of see how different communities are sharing resources. And finally, sharing resources among health departments to support CHA and CHIP. So shared services may be able to gain traction in Nebraska. When the health departments share the resources, they gain economies of scale for tools like survey platforms, dashboard software, printing materials. They develop a shared expertise in data analysis or facilitation. They align their timelines, creating consistency in how the CHAs are conducted across the entire region. This approach really helps smaller health departments that may not have dedicated staff for every CHA function, but it also helps those larger health departments as well with understanding the diversity and being able to share their skills and maybe have a codependency built in there as well. It strengthens those relationships between jurisdictions, builds that peer support, and allows for joint grant applications or policy alignment, which is much more powerful as well and benefits everybody. So if your department hasn't explored sharing services yet, I strongly advise that you look into it. So now wrapping up Module 6. So the key takeaways: stretch what you have, use the students, templates, shared staff as much as you can. Share across agencies. Consider inter-health department planning and data work, and maybe even formalize some of those agreements as much as you can. Seek sustainable funding. Align your grants with CHA priorities, not the other way around. And workforce is infrastructure, so invest in the skills to create your CHA resilience. And for the next steps, there's the quiz here, obviously, but I'd also suggest you look at that Stretch Share Seek planning tool, see how it might be useful for your community. Look at those funding opportunities, and right now is a very dynamic time in the public health sector and just in funding in general. So I don't know how dated it's going to be, but the general concept of going out there and finding funding that you might be able to share is essentially what I'm trying to get at here. So coming up in Module 7, we'll talk about CHA facilitation methods, talk about templates, checklists, and community meeting agendas, technology for collaboration, communication, and reporting, and some practical walkthroughs of editable tools and digital engagement aids. And here's some additional resources mentioned on the previous slide that might be useful for you.